Hey everyone, it's Karen, and I'm here to talk to you about gestational diabetes. This is a condition that's typically diagnosed in the second or third trimester. And though there are risk factors, this condition can occur with women who have never had diabetes before in their lives. What's happening is when a woman becomes pregnant, her placenta begins to secrete hormones in order to provide more glucose to the growing baby. This results in an insulin resistance in the mother, which then causes the glucose to begin building up in the mother's blood instead of being absorbed in her cells. Other factors that might affect the mother's ability to produce insulin are maternal obesity and stress. So what's actually happening is, in order to compensate for the insulin resistance, her pancreas increases insulin production. And when this production can't meet the body's demand, the result is a higher than normal blood sugar. Some of the risk factors that might increase a woman's propensity to develop gestational diabetes include these that you see here: pre-pregnancy obesity, advanced maternal age, if she had a previous child that was larger than 4,000 grams at birth, a previous miscarriage, and she may have pre-existing hypertension or may develop it during her pregnancy, having glucose in her urine, a history of polycystic ovary syndrome due to the fact that that particular syndrome increases the blood sugar in the body, family history of type 2 diabetes, and a prior history of gestational diabetes, as well as environmental factors, are all things that enter into the equation. Some of the environmental factors that we might consider include walkability or roadway proximity. Is there a place close by where she can just get out and walk that's safe and accessible to her so she can get some exercise? Air pollution. Does the lack of clean air prohibit her from going outside to walk? Also, access to healthy food resources. Eating healthy can be expensive, and many women can't afford the recommended diet or just don't have access to those resources. So it's imperative that we provide as many resources as we can so they have the best opportunity to keep themselves and their growing babies healthy. Here's a list of some common complications that might result from this condition. And you can see that some of them were also included in the risk category. A common result is either a baby that is larger than 9.9 pounds or one that has experienced intrauterine growth restriction. Hypoglycemia due to low glucose concentrations. Jaundice may occur due to hepatic immaturity or a decrease in extracellular fluid. Polycythemia occurs when an increase in oxygen consumption results in decreased oxygen to the fetal tissues from poor placental perfusion. Respiratory distress syndrome is not as common, but it is often seen in mothers with gestational diabetes that's not well controlled. The lungs aren't able to mature, and there is a decrease in phospholipid phosphatidylglycerol, which stabilizes the necessary surfactant the baby needs to breathe when they're first born. Childhood obesity is also an unfortunate consequence for the children that are born from these mothers. And birth injuries might be due to the size of the baby, and shoulder dystocia is one example. This occurs when the shoulders don't spontaneously follow the delivery of the head, and the infant gets stuck in the birth canal. This also increases the mother's risk of hemorrhage after the birth, another complication. Preterm labor and delivery, an increase in amniotic fluid, and the fact that the mother may develop hypertension when she previously had normal blood pressure. Mothers also have an increased risk of developing preeclampsia, and if the fetus is unable to handle the contractions or the placenta is not perfusing, they may have to deliver by cesarean section. And even if the mother has never had diabetes in her life, developing it during her pregnancy puts her at greater risk of developing it in her future. She may also be susceptible to urinary tract infections and yeast infections. Most women aren't even aware that they have a problem until they go in for their regular screening. If they do have symptoms, they often mistake them for pregnancy symptoms, peeing more often than usual, increased hunger and thirst, and they may even experience weakness, dizziness, and weight loss. So other than the weight loss, she may attribute these things to being natural occurrences during pregnancy. The screening is typically done at 26 to 28 weeks, and the most common one is the two-step process. Step 1 consists of a 1-hour 50-gram glucose test where the mother is given 50 grams of glucose, and then her blood sugar is tested. If she gets through step 1 with the normal blood sugar range, she's good to go and doesn't need to go on to step 2. If, however, her blood glucose is higher than the ranges that we see here, she goes on to the fasting test, step 2. She's instructed to eat complex carbs until it's time for her to fast. Some examples of complex carbs would be oats, wheat, skim milk, lentils, carrots, and spinach. She then fasts as instructed by her physician, comes into the office, and is given 100 grams of sugar to drink all at once. If her blood sugar equals or exceeds 2 or more of these thresholds, she is diagnosed with gestational diabetes. A diagnosis of diabetes often fills the mother with many different emotions. This isn't something that many people have a lot of knowledge or awareness about, and she may feel overwhelmed and not sure what to do next. She often feels fearful and anxious about how this is going to affect her and her baby's health. She may even feel guilty and blame herself, thinking she could have prevented this from occurring. It's really important that we reassure the mother that this condition can be managed, and often without medication. Referrals to groups in her neighborhood where she can gain support and information will help alleviate some of those concerns. So now that she's completed the first step of screening, her physician will most likely connect her with a dietitian who can help her put together a meal plan that's going to work for her. She should be eating about 3 meals and 2 to 4 small snacks a day, and it should include a well-balanced diet. She will need to incorporate carbs, protein, healthy fats, iron, calcium, fiber, vitamins, and sodium into her daily diet, as well as avoiding those foods that are high in refined sugar and fat. Some examples of healthy carbs might be winter squash, whole grain bread, brown rice, apples, grapes, and chickpeas. Lean protein food examples might be fish, poultry, cottage cheese, peanut butter, and tofu. Examples of healthy fats might be avocados, olive oil, sesame or sunflower seeds, and nuts. And she should also make sure she is incorporating enough fluid into her diet. About 8-ounce glasses a day is the recommendation, and that's water, juice, or milk. A bedtime snack is a good idea to prevent hypoglycemia at night. She's going to want to monitor her glucose weekly, and this is going to provide feedback on her self-management and help to determine her glycemic control. If she's able to bring her records to her physician each visit, along with her food diary, her physician can give her feedback on how well she's doing on her diet plan and blood sugar maintenance, and that's going to encourage her in her ability to take control of this condition. It's important that she feels confident in managing her condition and that she sees success along the way. It's recommended that she check fasting blood glucose when she gets up in the morning, and then about 1 to 2 hours after meals. Exercise is a critical element when it comes to managing blood glucose, as it decreases glucose levels without having to use insulin. You have to keep in mind that a woman who hasn't developed a regular exercise routine is going to want to incorporate it slowly and after she's eaten something. The recommendation is 30 minutes a day of exercise on most days, taking into consideration the mother's level of comfort. You can see some of the recommended forms of exercise here: walking, swimming, and riding a stationary bike. It's important that she always have snacks with her when she's exercising to keep up her energy stores. And if diet and exercise aren't able to keep her glucose at a healthy range, the physician may prescribe insulin to avoid any complications to her or to the baby. Meanwhile, while the mother's managing things with her diet and exercise, the physician's also going to be monitoring how the fetus is doing with all the changes occurring in her body. They're going to want to ensure there's a good deal of fetal movement as the baby continues to grow. Ultrasounds begin as early as 8 weeks, and she'll have an ultrasound with every prenatal visit. The ultrasound can estimate the size and weight of the baby, as well as estimate how old the baby is. It can also detect the location of the placenta, as well as determine the amniotic fluid volume. This will help to determine the fetal perfusion and hydration status. At 28 weeks, the mother can begin daily fetal movement counting, and at each visit to her physician, the ultrasound will continue to determine the size of the baby. At this point, if there is evidence of intrauterine growth restriction, poorly controlled glucose, or polyhydramnios, they may decide to begin planning for a biophysical profile or amniocentesis. The biophysical profile can be done at week 32, and an amniocentesis is typically done at weeks 37 to 39. However, these are only done if there's a risk of the baby that's detected. Non-stress testing is done to ensure that the baby's heartbeat is responding to the stress of being in utero, as well as whether the baby is well perfused. This test would be started between 30 and 32 weeks in patients with diabetes. And what we really want to see in this test is at least 2 accelerations of the fetal heart rate that are 15 beats per minute above baseline that last 15 seconds or more over a 20-minute time frame. If we're performing this test before 32 weeks, the heart rate should be 10 beats per minute above baseline. We're looking also for variability, which is going to tell us if the baby is well oxygenated. This would be considered a reactive test, and it's always good news. If we don't see any accelerations or variability in the heartbeat, or the accelerations don't meet the criteria of 15 beats per minute above baseline for at least 15 seconds, this would be an indication of poor perfusion, and it would require some more investigating. We may decide to reposition the mother to try to increase the baby's perfusion and then retest her and see if that makes a difference. Once the mother goes into labor and is hospitalized, we're going to hook her up for continuous electronic fetal monitoring so we can watch how the baby's responding to her contractions. Another thing that we're looking for on this monitor is the mother's contractions. We want them to be regular, about every 2 to 3 minutes as she gets closer to delivering the baby, and they should last about 60 to 90 seconds in duration, and we want them to be strong. While we're doing this, we're also monitoring the mother's glucose levels every hour. We want to maintain her glucose between 70 and 110. And if she's on insulin, we're going to get a drip going for the early stages of her labor. We would most likely discontinue it at the end of the 3rd stage as her need for insulin decreases at that time. Ensuring that the mother's well hydrated throughout her labor is critical. We may have 2 IVs going in case an insulin bolus is needed during labor. During this time, we're also going to be performing non-stress tests on the baby to ensure there's still movement and perfusion. As we're watching the monitor, we're not just looking for accelerations and variability to ensure movement and perfusion, we're also looking for any decelerations, primarily late or variable. This is going to tell us if the fetus is able to manage her contractions or if it's being stressed. Late decelerations would indicate decreased perfusion of the baby, indicating the baby might be in trouble if it's not fixed. If we see fetal tachycardia occurring, there's a risk of fetal hypoxemia. And lastly, if there are variable or prolonged decelerations, this is a serious issue indicating the baby is in distress. At this point, we may begin preparing for a cesarean section. Once the baby is delivered, the priority is ensuring the baby is able to cry loudly and that there are no indications of respiratory distress, such as the need for resuscitation. If the baby's crying and beginning to pink up with an APGAR score of at least 7, we want to get him or her on the mother's breast as soon as possible. This is because when the baby is in utero, the umbilical cord is supplying glucose to the baby. But once the baby is born and the cord is cut, the blood glucose supply is cut off and the levels drop very low in the baby while the insulin levels remain very high. This creates a risk of hypoglycemia, and the best thing at that moment for the baby is to breastfeed to get the glucose levels back up. Once the baby has been able to feed and we've given the parents and baby time to bond for about an hour or so, we're going to want to perform a glucose check on the baby to determine the risk of hypoglycemia. You can see here some of the indications that we might see in a child that has hypoglycemia. A CBC may also be performed to determine the baby's hematocrit level due to the risk of polycythemia. And we're going to begin monitoring for jaundice, as well as any signs of birth trauma. You can see some of the things that we would look for here in a child in this situation. We're going to want to monitor the mother's blood glucose to determine if it's back to normal. It should go back to normal once she gives birth to the child. And so if it is normal, we're going to reassess it at 6 weeks and then again at 3-year intervals due to her risk of developing type 2 diabetes. Here are just some of the local places in our area that we can actually check with. They've got all kinds of information on gestational diabetes, the Skagit Regional Health, Multicare, and then Swedish Diabetes Education Center. These are all places that women can go to for more information and knowledge and to help kind of alleviate their worries. Thanks for listening and have a great day, everybody.